Hello, this is Chapter 7, Screening and Assessment. This lecture video is actually only going to be a one-part video. This is a little bit of a shorter chapter, so some of the materials that I want you to focus on or cover for this chapter, it won't take as long to explain or discuss with you. So therefore, there isn't a second part to this video. So it's just Chapter 7. With this chapter, I'm hoping that you will get a better understanding of what a screening tool is and, what an assessment looks like. Both of these tools are, very helpful in the treatment world. So you may or may not see these types of tools depending on what type of job that you're looking for, what type of, what area of the field that you're looking to go into. However, it's good to know some information about it. And possibly, you may need to use it for, a different reason than, you would expect. So let's move forward and discuss some of these things. So first things first is, what is the purpose of screening and assessment? When you meet a client, whether it be face-to-face or you talk with a client, be it over the phone, you're having that initial point of contact with someone. So the purpose of screening and assessment is to be able to talk with them and figure out, okay, why is this person here? What are they coming here for? Or why are they calling in if it's over the phone? It qualifies a client with an appropriate problem. We have not yet made a diagnosis, so we can't officially say that this person has a mental health disorder or a drug and alcohol disorder. But we are saying, okay, we think there's reason to believe that there might be more to this client and that we need to meet with them and do an assessment on them. It allows the agency to get reimbursed based on the appropriate diagnosis. And it gives the therapist information who will be assigned the client. So if you have someone who does screening and assessment, they're going to gather information about this person and be able to pass it on to the next person who will be working with them. So it's kind of like their initial piece of information that follows them throughout the program and will help people, whoever comes in contact with this person, have a better understanding of who they are. The downside to screening and assessment is that, you're asking this person a lot of questions. So it can be intimidating, it can be uncomfortable, it can be awkward, and it can also be very discouraging for the client because they may not be in the mood to answer all those questions. Remember, if you're working in drug and alcohol, or even mental health for that matter, you're probably seeing someone at one of their worst times. More so with addiction than maybe mental health. They may have called you on a good day. But with drug and alcohol, if somebody is committing to getting help, there's a good possibility that they're high. So it could be discouraging that they're sitting there and answering all these questions and they could just get fed up and throw their hands up and say, I'm done. I'm out. I don't want to do this whole treatment thing. So it's really important that you try very quickly to build that rapport with that person so you can get a better understanding of who they are and get them to come back. Because it's not just you don't want to just be able to have to worry about billing for the services, but you want to make sure that this person comes back and that they feel welcome enough to come back. Another thing that is starting to become common, which could be a better thing, would be assessment as treatment. So you're continuing to assess that person as they're coming in for treatment so that you're not bombarding that person right off the bat with a million questions. So what they consider that is formal assessment over a period of time, which is also a very good tool that you could do. Something that you need to be aware of is assessment instruments are not usually cultural sensitive. So that could be an issue as well. But there are some good ones that are culturally sensitive. You would just have to be searching that out, or your company or facility would have to search that out. There is something your textbook talks about. It's called the SBIRT model, and that stands for Screening, Brief Intervention, and Referral for Treatment. This includes the universal screening for addiction and mental health problems, further assessment and brief intervention for those at a risky or harmful level of problem, and referral to treatment for those who may have a disorder. So that is something that, can indicate or can help refer a person if they do need further treatment. Screening and assessment varies according to the setting that you're in. You have home-based treatment, emergency room, prison, primary care office, a shelter, detox center. There's a lot of different places that you may come in contact with a person who has addiction or mental health issues. So screening and assessment can be done in any of those various settings and should be done in any of those various settings. Screens are used to find out if there is one or more problems. Your textbook actually says that it filters out the negatives and lets through the positives when you screen someone. Typically screenings are done for all clients. So they're usually asked of all clients or patients in primary care settings or, any of the settings that we listed above. This is interesting because of the Affordable Care Act. Insurance companies are increasingly covered by insurance plans. So they're covering these screenings. So what may take a few moments are starting to be covered by insurance companies. That is definitely something interesting under the Affordable Care Act. A very simple question that gets asked is, do you sometimes drink or use drugs? If the answer is no, then you don't really need to go any further. But if a person answers yes to that question, that's when we kind of get a little bit more into it and we use some of these other different tools that are out there, are available. SAMHSA recommends a one-question screen that is part of the SBRIT model. You can look at that on page 298 of your textbook, but I'll briefly give you the example here. Men are asked, how many times in the past year have you had 5 or more drinks in a day? And for women, how many times in the past year have you had 4 or more drinks in a day? Again, there are also questions for behavioral health problems too. In one study, it identified that 86% of individuals with an alcohol use disorder just by using this one screen question. There are longer screens available. Those screens, the short version of that is CAGE and TWEAK. So those are longer screens that are available. On page 299 of your textbook, it references this. TWEAK is better for African American and white women due to the tolerance question. So if you're screening for both genders, this might be a good one to use. Again, we mentioned that not all screens are culturally sensitive, but I guess from research and experience of working with that particular screen, the textbook suggests that this would be a better one for that population. Audit Alcohol Use Disorders Identification Test was developed by the WHO for international use. It can be administered as a questionnaire or in an interview. There is a website that is provided in the text, so you could take a look at that and see how it works. And then there's also DAST, which is for drug use. Moving on to assessment. So the screen is giving you a sense of what is actually going on, but an assessment is more narrowly telling you about the problem so that you can actually develop treatment strategies. So the assessment's breaking it down even more with your client or patient, however you identify with them, and helping the person who will be working with them, more than likely the therapist or doctor, so that you can start building a plan or start working on what the goals are for that person. If you like assessment tools, make sure you check out page 302 for an overview. That's definitely something that you can kind of see what different tools are out there. I have included the Inventory of Drug Use Consequences Assessment and Scoring Guide in the Module 4 files for you to review if you chose to do so, just so that you could get an idea and it's easily accessible for you to take a look at it. There won't be any, questions on your quiz or testing or anything like that on it, but it's just something to, a tool that you could look at or review for more knowledge. The Substance Abuse Subtle Screening Inventory, known as the STEALTH assessment, has one side that gives you a profile consistent with chemical dependence without asking directly about drug and alcohol abuse. So it's kind of like a sneaky way of getting to the root of what you're trying to get at. So that is one way that you could do it. But the issue with that is you're sneaking it up on the client. You're not really directly asking them about drug and alcohol, but it could be an ethical issue because you're kind of, going around the obvious answer and kind of almost like tricking them. So that could be an issue with that particular with that particular assessment. It is supposed to be good for defensive clients and a way for therapists or screeners to be able to detect honesty. So that's a little bit about assessment there. Moving on to assessing levels of care. So once we've screened a client and once we have an assessment that we like, that gives us more information about the client, we need to assess based off of what information we have found is what level of care does this person meet. So the American Society of Addiction Medicine's ASAM is the shorter version of that criteria, is treatment criteria for addictive substance-related and co-occurring conditions. So there are 5 levels of care. We have 0.5, which is your early intervention. Level 1 is outpatient. Level 2 is intensive outpatient or partial. Level 3 is residential inpatient. And level 4 is medically managed intensive inpatient treatment. So those are your technically 5 levels of treatment that, a person could fall under. Just to kind of give you a brief, I guess, quick rundown of what you might see in these these levels of care. Your early intervention type treatment is more than likely going to be just some like education type classes. I often refer to early intervention. The best example I can give you from my experience would be underage drinking classes would fall under this early intervention. Early interventions typically aren't usually covered by insurance companies, so this would be like an out-of-pocket educational type thing that a person could go for. Now, there may be other early intervention programs out there that insurance companies do pay for, but that's just in my experience and my best practice that I've found that qualified for early intervention. Outpatient treatment is something that a client would actually stay at home and they would just go to a facility, once or twice a week, and they would participate in group therapy, individual therapy, something like that. Most programs usually do both group and individual therapy. So they may go to group 1 time a week and do individual therapy 1 time a week or every other week. Intensive outpatient treatment, I'm going to start with that one and then I'll explain partial. But intensive outpatient treatment tends to be about 3 times a week, give or take. If their individual session is on a different day, it might be 4 times a week. But intensive outpatient treatment is, a couple hours, multiple times a week, and you're getting a little bit more intense treatment. So it allows the therapist to have a little bit more contact with that person so that they can kind of keep a better eye on them and see where they're at, and they are more available for them to help them when they have issues or things that arise. A partial program is more like a day program. It depends on what the facility offers. Of course, it might be like a half day program or a full day program, and that days of the week would depend on whether it was like a half day program or a full day program. But you're going several times a week again, and you're having longer sessions, longer groups, and longer, therapy so that you can address some of the issues that you need to address while still being at your own home. So you're not being taken out of your home environment with that. Residential or inpatient treatment is where a client is actually going to a facility and they are staying there for a period of time. Inpatient treatment usually detox treatment comes first and then inpatient treatment comes next. So detox usually lasts a couple days, 2, 3, 4 days, depending on what a person is using and, how rough their withdrawal symptoms are. Detox is not usually a treatment thing. It's usually just more so allowing that person to kind of come off of whatever drug that they're on. Then they will start the treatment process in inpatient treatment. So in inpatient, you're living somewhere, you're getting fed, you have a roof over your head, you have a bed, and you're kind of removed from your home environment and removed from the situation, which is good to kind of take a person out of it so that they can actually focus on the treatment that they need to focus on. The last one is medically managed intensive inpatient treatment. So typically this is recommended if a person, has it's usually like the most severe. There's not very many medically managed places around, but it's for people, maybe with alcohol withdrawal that might be having like those seizures, different things like that. It's in a medical setting where you're going to have doctors and nurses on hand a little bit more than you would in an inpatient facility. They do exist. These medically managed programs are out there. There's just not, you would need a medical reason in order to go there, or maybe you have a pre-existing medical condition that would put you into a place like this. I can't think off the top of my head when I used to do case management what would kind of qualify a person to need the medical managed treatment versus just a regular detox inpatient. I want to say like probably if you had any like pre-existing like heart conditions or anything like that, anything that would require you to possibly need more medical staff than just a typical withdrawal detox situation, that would be your level 4 treatment. All right, so now that we've covered that and you have an understanding of that, let's move on. All right, this may sound a little bit familiar from the previous chapter, but a different system describes the capability of programs to serve clients with co-occurring disorders. So there are 4 levels with this for co-occurring disorder. We have the basic level, level 1, and you're screening for both drug and alcohol and mental health, but only treating for one. Level 2 is your intermediate level, and this is focusing on one disorder but addressing some of the needs of the other disorder. So whether it be mental health, and then you address the needs of drug and alcohol, or vice versa. Level 3 is your advanced level, and you're providing services for both disorders. This is integrated treatment. And level 4 is fully integrated, and it's complete integration of treatment as well as funding. So you're getting both drug and alcohol and mental health, and it's fully integrative, and the funding for both is available. There are some assessments for people with co-occurring disorders. It definitely makes it a little bit more challenging. It raises complex issues for the practitioner, which may require more patience, empathy, and keeping hope alive. Because not only are you treating one disorder, but you have a second disorder too, a second underlying issue. So it tends to get a little bit harder and a little bit more complicated. But you can work with your team to figure it out, because not one person has all of the answers for it. And again, we've talked before that sometimes one condition may make the other condition worse, and you can't always tell which condition is kind of like the preliminary issue, or which is which, or which came first. And it may take weeks, months, a long time to really figure that out. And you may not have that long to work with that person. So you just work with what you can as you get it. Go along with it, I should say. Some skills that you need to have when you're working with co-occurring people is, know the typical DSM criteria, and, have a quick reference guide. I had a little pocket DSM book that I would always keep by my desk. I didn't have to reference it a lot because in a lot of my roles, that wasn't necessarily my job to be doing the diagnosing, but I always had it there for reference. If I would see these things come across my charts, then I would be able to reference it so I could have a better understanding of what I was working with. Know the typical psychiatric medications and potential interactions. Again, you're not expected, depending on what your job is or what your role is, you're not expected to know everything about everything. So I, just from experience, can tell you that as you see the names of these different types of medications float across your desk, that's how you become familiar with them. I didn't take any special training to be more aware of psychiatric medications, but in the field, you would start to pick up on some of these things. I would say that I didn't necessarily know all of the interactions. I may have been aware of a few things, but it's definitely something. Be familiar with the things that you're working around. And it's not going to happen overnight, but it'll take time with experience. And then you'll be able to, at least know what's going on. And again, you can always ask for help. I wanted to mention, there's a suggested reference guide for the psychiatric medications and potential interactions. For those of us who don't know all the medications, because there's generic and then there's brand names, and the purpose of each, doses, side effects, and how they are abused, you can download it for free or order a copy at a small cost. It's actually on page 304 of your textbook. I had a little note that I wanted to remember to let you guys know that. Continuing on with skills that you need to have is know the policies of your organization about who you can talk with about what. So are you allowed to talk with family? Are you allowed to talk with probation, any other criminal justice professional, or what other treatment providers can you talk with, or what other people within your agency can you talk with? Have a supervisor or consultant that you can talk to. Again, no one has all the answers. So if you have someone above you that you feel comfortable talking with, that would be, good to have. And know your community resources. So there are so many different resources within your community that you may not even realize are out there, and you can help refer people to. There is no reliable and quick screening tool for people with co-occurring disorders. There are two options. You could use one of each type, whether it be a drug and alcohol screening tool and a mental health screening tool, or you could use one that's not quick, which is CAAPE, CAAPE. And that is actually on page 306 of your textbook. It is a 30 to 45 minute interview. So it's not a short thing, it's a lengthy one, and it's not free to use. So you would have to pay for that. But that is one that you could use that would screen and assess screen for co-occurring disorders specifically, both together. What else did I want to tell you about? Simple screening instrument for substance abuse, self-assessment form. There's, that's in the box 7.3 on page 305. It's a 16-question screen with yes or no answers, so that is an option for you. There's a mental health screening form 3, screens for most of the main mental health disorders, but only one question for each behavioral health disorder. So whether or not a person answers it right away, it would indicate whether or not that behavioral health disorder is being addressed or not being addressed. And that's described a little bit more in page 306 of your textbook. If you want to screen for eating disorders, there's screenings out there for that as well. Page 306, you could reference that for eating disorders. So, we mentioned that screening and assessment isn't necessarily cultural sensitive, but there are different screening and assessment tools for the use of older adults. With that, we have those baby boomers that we were talking about before, and, they're getting older, and with them, they have a whole different list of issues, that they need to address. So we have, screening and assessment tools that might be better for using with people, that are considered the baby boomers. We're far short in the number of practitioners needed, so we're always in need of psychiatrists, social workers, psychologists, nurses, and physicians who are trained to work with these types of disorders. We've talked about the issues with the older population as well, being that it might be more likely to go undetected. There's different drug interactions that we have to worry about. A person's body is metabolizing different as they get older. Drugs and alcohol have a greater impact on their bodies. They're higher risk for falls and depression. I mentioned more interactions with medications. They aren't seen as using as much as young people, so that hidden factor. And substance abuse issues may be viewed as cognitive impairment. And some barriers to treatment include, transportation. Maybe they don't have the transportation to get to their treatment. Lack of trained professionals. So maybe there aren't as many people out in the field that are able to work with older adult population. And the lack of screening and assessment by providers with related lack of training. So maybe the screening and assessment isn't as efficient in working with older adults, or, that one simple question, they may not answer that correctly. So therefore their conditions may go undetected for a period of time. So some things to keep in mind with that. And some screening questions are not appropriate for older adults, like occupational consequences of misuse, because they may not be working. 2 alcohol screening devices validated for use with the older adults would be CAGE, which we've already mentioned, and the geriatric MAST, and that has 24 questions on it. And the text mentions a screen for depression in older adults, because about 25% of older adults have depression. So something to kind of keep in mind or focus on with the older adult population. We come to diagnosing addiction problems. So now we have this screening and we have this assessment, and now we need to look at diagnosing. So we're going to use the DSM-5 or ICD-10 to diagnose. ICD-10 is used by international clinicians, but it is widely used in the United States as well. The DSM-5 is something I mentioned earlier. So it's going to tell you, what a person needs to meet the criteria for schizophrenia, major depressive disorder, generalized anxiety disorder. There's a lot of different things that a person would, could be diagnosed with, and that little book would be able to help you. I believe it's actually referred to as a manual, but diagnosis done through an interview by a licensed physician, psychologist, or social worker, comparing current symptoms and behaviors to the DSM or ICD criteria. This would require training. Diagnosis alone does not determine how to proceed with treatment. So even though a person may have a diagnosis, there is no textbook way on how a person will be treated after that. However, it's good to know what diagnosis a person has so that you know kind of how to base some of your treatment on working with them. However, both tools are deficit focused and does not focus on strengths. Again, we're labeling a person with a disorder. And that could be an issue all in itself too. However, with billing purposes, we do need that diagnosis, so it is an important part of the treatment process. Assessment and the strengths perspective, which is a different approach. You want to, we mentioned earlier when you screen or assess a person, there's a lot of questions involved. A different way that you could handle that is listening to the client's story first. And then saying, after a while, we will ask you some questions that we ask everybody. But first, I want to know, why are you here? What's happening in your life and how we might be able to help you. So if you start by putting it in the client's, area first, like let them decide why they're there, let them tell you what their story is, and not just jump into asking them standard questions that you're going to ask everybody that walks through that door, might be a little bit more beneficial, and you might be able to build better rapport with that client. So it will also increase the retention rate, that they're going to come back for services as well. And again, that rapport relationship has been built with that person. If we focus on deficits and weaknesses, it reinforces that clients are screwed up and they're not the system of poverty, racism, and equality that can foster addiction and other problems. So if we focus just on those bad things, all we're doing is saying, okay, this is who you are. This is what we're labeling you as. We're not giving you strength or hope to actually overcome what your issue is or overcome your problem. Something, I think this says it very well. It's the person being the problem versus the problem being the problem. So the person becomes the problem, not the problem being the problem. And that's on page 310 of your textbook. I like that quote. So something I want you to think about is, what is your mental image when I say crack mothers? Be honest with yourself. Media and other knowledge leads us to believe that these labels define a person or what a typical person should look like. And I used to have my clients actually draw what they thought an addict looks like. And, some of them thought I was being silly and, why am I drawing this? I don't understand. But we would have groups, extensive groups on, okay, so, before you became an addict, what did you think an addict looked like? Now that you are an addict, what do you think an addict looked like? So I ask you to kind of think about that too. What does an addict look like to you? When I say crack mom, what does that look like to you? What is the first vision that kind of pops into your mind? There was another activity I used to do with my clients that I liked activities like this. I like to, kind of help keep your brain fresh. And I would say a word and I would ask them to write down or, draw what was the first thing that came to mind when I said that. So I would say relapse, recovery, and, give them a couple seconds and they would have to, tell you, well, this is what I initially thought of. Same type of activity, but, going off that first perception. One last thing I want to address with you guys are the principles of strengths-based practice. The problem situations and people's perceptions of them are frequently changing. We also want to think that people are basically trustworthy. Their perceptions of reality need to be understood, not necessarily accepted. So as the therapist role, you may not necessarily accept what their reality is, but you will understand what their version of reality is. And again, that version of reality will change the more that they go through treatment. And it's valid from their perspective. Whatever they believe, it's their validation of their perspective. If the person doesn't want to be here, how do we respond to them? We accept that as valid and find out what needs to happen so that they do not need to continue to keep coming. It is their choice on what to work on, not ours. Everyone wants something, and most people will work to get what they want, not what we want them to want. So if we set goals for them, they're not going to be as inclined to work towards them. But if it's their goals and their motivation, then they will continue working on them. Every person, no matter how messed up they may seem or how messed up they feel, has strengths. A diagnosis is just a diagnosis. It does not define the person or limit how they might change. Exception questions are very useful. And more than strategies, people want to know I am there with them, to know that I see their pain and that I'm not afraid of them and that I can hear their stories and will stick with them when they feel unworthy. I help them to see what I see, a person deeply inured and with great unbelievable resilience. That's a quote from page 312 in your textbook. But I think it's a very important one because you want to know that you want the person, your client that you're working with, to know that you're hearing them, that you're understanding them, and that you're feeling something for them. If you're going to work in this field, you have to have some degree of empathy, and you have to be able to have some understanding of what a person is going through. Because if you are kind of just cold and no emotion with a person, you're going to have a really hard time working with them, and they're not going to open up with you, and they're not going to feel safe and comfortable. So I think that quote, is a really good one to kind of keep in mind for working strengths-based wise with a client. That is chapter 7, screening and assessment. So hopefully you were able to get a better understanding, again, a very quick run through of what screening and assessment looks like, to better help you understand the treatment process and how a person gets started in it. Thank you for watching.